old technique of treating cancers. It has been effective for more than 100 years. And if you see the data, it's a data from IAEA that around 60% of patients diagnosed with cancer will receive some form of radiotherapy as part of the treatment. So radiation oncologists, like me, are cancer specialists who manage the care of cancer patients with radiation for either cure or palliation. So when we start principle of radiotherapy, I would like to divide this into what is radiation therapy, how radiation is given, why radiation is given, how it is given. We'll go into discussion later. What are the types of radiation available in world and what we do in Nepal, and how is the process of radiation goes on. So radiation therapy, as you must have known, is ionizing radiation delivered to kill tumor cell at microscopic as well as macroscopic level. It induces damage at cellular level, which we all know. The source of radiation may be different. Sometimes it's a radioisotope like cobalt-60, which is used, or it can be a linear accelerator, which actually is a large X-ray machines. Or sometimes even heavy ions are used. So how actually radiation works? So the ionizing radiation acts on DNA. So it causes double-stranded break as well as single-stranded break, which is the direct effect of ionizing radiation. Double-stranded break are irreversible and the DNA dies. So when we treat a tumor, there are surrounding normal tissue also. So the tissue which undergo double-stranded break actually undergo apoptosis. There is also an indirect method when radiation acts on the water of the shell, and it causes a hydroxyl ion, and which in turn causes single-stranded break. So double-stranded break are irreversible. So when even the tumor as well as normal tissue are affected by DSP, but only around 37% are actually DSP, double-stranded break. Around 67% are single-stranded break. So, as we know, tumor cells are a rapidly populating cell. So during this rapid population, they actually forget how to repair the cell. So this actually is taken in advantage while giving radiation. So when the single-stranded break are done, the normal tissue, which has the normal repair mechanism, usually repairs. But the radiation, but the tumor or cancer cell, which has the deficient repair mechanism, cannot repair the cell. So they in turn die. This is how radiation works at a cellular level. So you must have heard during our residency that how was the radiation planned? So usually it's 50 gray, 60 gray given in 25 fraction or 30 fraction in 5 weeks. This we call a time dose and fractionation of radiation. So there is actually radiobiological explanation why radiation is given in such a way. It's also famously called 4 R's of radiobiology. So when radiation is given, it affects tissue response. The fractionation causes differential tissue reaction. So it's called, first is repair. As I have already said, the sublethal damage to cell between fraction caused by radiation. The normal tissue repairs and the cancer cells cannot repair. Another is repopulation. It's the regrowth of cells between fraction. We'll go into detail. Redistribution of cell. We know the cell has different cycle, and some cells, some part of cell cycles are radio resistant, while some are radio sensitive. And reoxygenation. The hypoxia cell are radio resistant. We all know. So how does repair act? Not all cancer cells die in first treatment. I have already explained. Around 67% of patient cells actually has single-stranded break, which has potential for the repair. The cancer cell have impaired repair mechanism, so daily treatment kill those cells. But healthy tissue actually repair within those fractions. So repopulation, when given radiation, cell repopulate after radiation treatment. So daily treatment are given to prevent cell from repopulation, so that cancer cell cannot repopulate rapidly, and which prevent accelerated growth. And the radiobiological reassortment. I have already said that certain phases of cell cycle are radio resistant, like S phase, and certain cycle are radio sensitive. When you give radiation today, so the G2 and M phase cell cycle are killed, whereas the S phase are not killed. So when you give another infraction another day, the G2M phase, the S phase goes into G2M phase, and in this way, all the cells are killed. So daily treatment allows for treatment to be captured in sensitive phases. We all know hypoxic cells are radio resistant. So in a large tumor cell, there is, despite neovascularization, the core of the tumor actually are hypoxic. So when you give fractionated radiation, after radiation, some part of cancer cells are killed, and then there are new neovascularization which causes the oxygenation of those hypoxic cells, and which helps us to kill those radio-resistant cells. So now coming to what are the type of radiation which commonly used. It's basically divided into teletherapy and brachytherapy. Tele, as the name suggests, is given from outside. And so how is radiation and just example, how is radiation produced? So radiations are produced by natural source like cobalt-60, iridium. These are basically radioisotopes which produce gamma rays during the fusion reaction. So also there are the linear accelerator. We must have heard all about the linear accelerator. These are the radiation machine used worldwide now. These are very powerful cathode ray tube which gives X-rays. So basically, linear accelerator are the machine which produce X-rays. So here electrons are accelerated towards a target. So because it's a man-made, we can change the energy of the radiation. So cobalt, our traditional radiation machine, here we use cobalt-60 as radioisotope. It's rarely used nowadays because of its limitation. Nowadays, much center use linear accelerators. Even today, there are some center which still use cobalt. So if you see compared to cobalt and LINAC, cobalt has a very limited energy, that's 1.25 compared to 4 to 20 linear accelerator. Maximum dose of cobalt is depth as 5 mm, whereas linear accelerator maximum dose can go up to 3, 4, 5, or 6 centimeter depending upon the energy. So deep-seated tumors in cobalt, we cannot give maximum dose without much side effects. In linear accelerator, we can easily give those doses. In cobalt, as we know, it's a radioisotope with half-life of 5.12 years, so source have to change. In linear accelerator, there is no radioactive source, so it's easier to handle. Leakage radiation present, since cobalt is a radioisotope, even we close the machine, there is a radiation always going on. However, in linear accelerator, there is no such problem. So in cobalt, there is higher penetration to deep-seated tumors because the deposition of the radiation is only at 5 mm. However, in linear accelerator, the deposition is high, so all kind of deep-seated tumors can be used. And cobalt produces a gamma photon, whereas linear accelerator produces electron beam and X-rays. So, brachytherapy is another method of radiation where this is a brachy machine where actually a radiation source goes inside the patient. So this is the if you see in this picture, this is the catheter through which the source goes, and this is an example of the breast, interstitial breast, where actually the source goes inside the patient. So since it's given within the patient, it's said brachytherapy. Mainly two sources are used: is either iridium or cobalt. So I want to give introduction about the radiotherapy workflow in our center. So what happened when you refer a patient to us or a patient come to us? So first is consultation. We'll go on. So when we consult a patient, we take, as every clinical subject, we take history examination. We review all diagnostic images. We review pathological reports. We stage the patient if not previously done. And we again review the indication of radiotherapy. And then after reviewing all these things, we actually formulate the treatment plan. So how much dose is given? Should we add concurrent chemotherapy? And then we explain patient about the treatment, prognosis, and side effect. This is all done usually within the first visits. Then simulation. Simulation is nothing but here we simulate the patients in the treatment position so that we know exactly how much dose is given. So this is the simulation. This is a simulator. This is a fluoroscopic simulator where here we can see the fluoroscope. So the patient is kept in treatment position and fluoroscope. By fluoroscope, we see which part of radiation we want to give. This is a 2D method in fluoroscope. And the second picture is a CT simulation. Here we can see it's a CT scan. We place the patient in the treatment position. We use the immobilization mask because today's radiation has sub-millimeter accuracy. So we don't want patient to move even a millimeter. So this type of masks are used in patients. And the patient undergoes CT scan. So this is called simulation. We use different type of immobilization based on type of cancer, on which side the cancer is. Then once the simulation is done, so I will explain with this example. We get the CT scan. The topmost picture is the CT scan we get during simulation. Then if we have other images like MRI or PET CT, we take it from DICOM images, and then we fuse these images. So this is a fusion image. Then we contour. So what's contouring? Basically, this is the tumor. We draw which is the gross tumor. Then in this case, we draw even edema. It's a T2 edema. So we give a clinical target volume around the gross tumor. And then we in the planning target volume. That's account for the movement of the patient. So after doing all this is called the contouring part. So this is the final one. Then the planning is done. In planning, we use multiple fields of radiation. So by doing this, we actually see how much dose the tumor is getting and how much dose the organoleptics are doing. This graph which is shown here, actually in today's radiation treatment plan, we actually know how much actually each of the tumor as well as organoleptics is getting. So we know accurately how much in this patient, because the brainstem is near, so we want to know how much brainstem is getting. So when we are convinced that everything is under control, because every organ has their limited dose which we should not exceed. When we are convinced that okay, the dose is not exceed, then we go to quality assurance, because what we have planned should be delivered to patients. So this is for every patient we do this quality assurance. These are the phantoms or patient equivalent. So after planning, we transfer this plan to this phantoms, and we see actually how is the dose delivered to the patient. Then we finally the treatment part. Once everything we are convinced that okay, the dose plan is accurate, then the treatment is done. This is the electro synergy which we have in our center at Kathmandu Cancer Center. It's a radiation machine. Then we do the follow-ups. In follow-ups, we do history examination, radiology, and tumor markers. So you must have heard about the different type of radiation. Sometimes they say IMRT, or sometimes they say in some cases IMRT are must. So what are these different type of radiation? So these are the radiation treatment strategies. There are different forms. It's either 2D, which are the conventional form, which no longer is used in many centers, and we don't use 2D in our center. It's either 3-dimensional conformal radiotherapy. It's IMRT, VMAT, or sometimes intraoperative RT is used. Stereotactic radiotherapy, you must have heard about stereotactic radiotherapy, or the particle beam therapy. So I must say that in Nepal, we have 3D CRT, IMRT, and VMAT. Intraoperative radiotherapy is not available in Nepal. SVRT we do in our center. SRS is not available in Nepal ticket. And particle beam therapy are very expensive. These are, even in India, there is only one center. In Asia, there are only 3 centers. So it's rarely available in the whole world. So what's actually this 2D, 3D? So it's basically a dose sculpting. So if you see the first block, it's a gross one, the rectangular block. So as we progress in our radiation treatment plan, we sculpt the dose accurately around the tumor. So in 2D, there is some form of sculpting, but it's very gross. In 3D, you can see there is sculpting. We know the shape of the tumor, but it's IMRT, which is the form of radiation. So here we actually sculpt the dose around the tumor. So what's the benefit of it is we get very, very, very less dose to organ surrounding normal structure. So if you see, in all this method, the tumor is actually getting enough dose, but it's actually the decrease in normal tissue that's very important, and that's what we achieve by going higher up. So if you see this is a case of shear esophagus. Here we do a barium salo in fluoroscopic simulator. We give 5 centimeter margin superior inferior and 1 centimeter margin laterally. Then we make a box and we treat this. This is a 2D method. It's rarely used these days. So this is very gross. We don't account for movement of the esophagus. We don't account of the subclinical disease. In 3D, we contour actually every organ. This is a case of CA rectum. Here you can see we have contoured the CA rectum, we have contoured the rectum, we have contoured the bladder, we have contoured the femoral head. So we have contoured the kidney. By this way, we contour every organ. Then we plan, and by that we can know actually accurately how much the tumor is getting and accurately other organ is getting. So in 3D CRT and IMRT, the contouring part is same. It's actually the planning that's different. This is 3D CRT. Here we use 3 beam, 1 posterior and 2 lateral beam. So we get the dose around the tumor. So it's basically how 3D CRT plan are made. Here you can see, if you see the contour here, external iliac, internal iliac nodes are contoured. So to cover it, it's a more of rectangular box kind of dose. In IMRT, there are multiple field use. This is a 9-field IMRT. So there are multiple field use. So what that does is sculpt the dose around the our target. So if you compare between 3D CRT and IMRT, yes, we are covering the target, this external iliac, obturator, internal iliac, accurately in both 3D CRT and IMRT. But if you see the dose of small bowel, it's markedly different. In 3D CRT, the small bowel is getting almost all of the dose, whereas in IMRT, it's getting very less. VMAT is volumetric arc therapy. It's a kind of IMRT where instead in IMRT, multiple small field are used. In VMAT, all is treated within a volume. So in most cases, it's not required. But however, in some cases where large field are used, like this patient is a case of extended field RT, where in rectum, we are giving dose to tumor as well as para-aortic node of the intrarenal region. So in such cases, VMAT has definite advantage over IMRT because a single volume is used. So in some cases like medulloblastoma, where we have to treat brain plus whole of the spine, in some such cases, VMAT has superior advantage over IMRT. Intraoperative radiotherapy is not available in Nepal. Here, it's an X-ray generating machine. So during the surgery, it's mainly used in pancreas, stomach, lung, esophagus, and most are experimental. Here, while doing the surgery, you open the tumor bed, and there are certain indications, like if the pancreas is attached to the celiac artery and you scrap it, then at the time of the surgery, you give radiation to the patient. Stereotactic radiotherapy and stereotactic radiosurgery are also kind of radiation. Here the planning is IMRT, but here high precision image guided radiation therapy is given with the intent of tumor ablation. And if it's given within a single fraction, it's called stereotactic radiosurgery. And if it's given within 5 fractions, it's called stereotactic radiotherapy. So the concept is, if we can precisely target our beam within the tumor, and there is very, very less normal tissue around the tumor, then we can deliver very high dose to the tumor. So here, the much of the damage is done by the necrosis and not by the single strand break. So dose is, we have seen that in fractionation schedule earlier, dose is around 1.8 to 2 gray. Here 20 gray or 30 gray is given within single fraction. Gamma knife is also kind of a stereotactic radiosurgery. It's a cobalt based and it's only used for intracranial and spine tumor. And here invasive frame is made. Linac-based stereotactic radiotherapy are commonly used. Linear accelerator is used here. Here non-invasive frame are used like this. And both stereotactic radiosurgery and SRT can be done by Linac-based. And it can be used for extracranial tumor too, which is called stereotactic body radiotherapy. So in stereotactic body radiotherapy, instead of brain lesion, we give radiation to the body lesion. We actually use commonly in lung lesion and hepatocellular carcinoma, especially with portal bone thrombosis. So here, 45 gray is given in 3 fraction or 50 gray in 5 fraction. So how can we deliver such a high dose of radiation? So if we can minimize the motion, then we can precisely target the tumor. Then we can deliver, the concept is we can deliver very, very high dose of radiation. So how to decrease respiratory? So yes, we can mobilize the external motion by using the frame, but we know during respiration, our organ moves around 2 to 2.5 centimeters. So how to decrease the respiratory motion? So one, we can restrict the motion. Second, we can deliver only when target is within field. A third, we can follow the target. So these are the immobilization devices. This is a backlog and this is stereotactic frame. This is stereotactic body frame, which is used for stereotactic. So gating is here, we follow the respiratory cycle using a surrogate indicator. Patient breathes normally and beam automatically turns on and off. So if you see, if we target only the tumor without the margin, during the respiratory motion, you can see the tumor goes in and out of field. So some part of the tumor will get less dose. So it's not the ideal scenario. So some technique like breath hold technique. We have special apparatus for breath holding. So when we hold breath, the tumor comes to a specific site, then only it's delivered. So it's in gating, the tumor, the treatment is delivered when tumor is within a specified area. So there is another method for tracking or chasing. So here we actually chase the tumor. So these are different methods of chasing the tumor. Commonly used chasing method is cyber knife. Proton beam therapy, here we delivered heavy ion proton beams. And the benefit of proton beam are they are very, very accurate. But as we said, these are very, very expensive one, and there are very few centers which deliver proton beam within the world. Now coming to brachytherapy, there are different types of brachytherapy like intracavitary implants, interstitial implants, or interluminal implants. Intracavitary implants is when we use radioactive source within a cavity near the tumor, like it's used in breast, cervix, or uterine. In interstitial, sources are directly placed inside the tissue, like prostate and vagina. In intraluminal, radioactive sources are placed in a lumen within a tumor, like esophagus and bronchus. So this is an example of intracavitary brachytherapy. This is a catheter. This is a Fletcher suit type catheter. This catheter are actually inserted within a uterus, and these are ovoid. So we deliver maximum dose around the cervix. This is another example of interstitial brachytherapy. It's a case of prostate cancer. Here we actually insert the catheter inside the prostate and deliver the dose. It's an example of intraluminal brachytherapy in a case of CA esophagus. Here, a brachytherapy catheter is inserted inside the esophagus and dose is delivered. What we have to know is cancer management is a multidisciplinary approach. So radiotherapy can be part of multimodal management or sometimes single management. So now we'll focus on who can benefit of radiation therapy. So as we have already said, around 60% of all people diagnosed with cancer can benefit from radiation therapy. So within our first consult, we actually try to know if our treatment intent is either what is our treatment intent and what are the multimodal therapy we want to use in the patient. So treatment intent can be either curative, palliative, prophylactic, or emergency, and treatment can be sole treatment or in combination with other modalities. So when you come to curative intent, the treatment aim is eradication of disease. So in curative, it can be definitive, adjuvant, neoadjuvant, and salvage. Definitive is when radiation therapy is the sole or primary treatment modality. Sometimes chemotherapy can be added as a radiosensitizer. So there are some sites where definitive radiotherapy is given, like in prostate, cervix, head and neck, lung, anal cancer, in some cases of colorectal, esophagus, skin, bladder, and brain. Here, radiotherapy is the sole modality with sometimes adding of chemotherapy as a radiosensitizer. So it's an example of definitive treatment. Adjuvant is radiation therapy is delivered after primary treatments. I think it's very important to know for the resident that what are these different terms like definitive, adjuvant, neoadjuvant, salvage, because we have to use the right term every time. It shows our intent, what type of treatment are we going to deliver. So adjuvant is when radiotherapy is delivered after primary treatments, mainly surgery. So aim is to reduce the risk of the cancer returning locally and improve survival. So some sites where we give adjuvant treatment is breast, rectum, cervix, endometrium, esophagus, head and neck, especially oral cavity, some skin cancer, and lung cancer. So another intent is neoadjuvant. So neoadjuvant is radiation therapy is delivered before surgery. So it's radiation therapy is given initially, then only surgery is done. So aim is to improve surgical outcomes, that's shrinking the tumor to improve operability, improve quality of life, and also to improve disease-free survival and overall survival. So some cases where neoadjuvant treatment are preferred are esophagus, rectum, sarcoma, and lung, especially the pancreas tumor. The salvage is when radiation therapy was not the initial plan, but when after the initial treatment, patient has residual disease, then we give radiation for the curative intent. That's called salvage therapy. So it's basically to eradicate residual disease. So one common example is prostate following radical prostatectomy. If there is residual tumor or PSA is high, then we give salvage radiotherapy to prostate. So in some time we give prophylactic radiation. It's to eradicate subclinical disease in order to prevent or delay the clinical spread of disease. It may provide benefit in those cancers where the pattern of disease failure is well recognized. One example is prophylactic cranial eradication to brain in small cell lung cancer. We know in small cell lung cancer, brain mets is the rule. So when we do any primary treatment and there is complete response, then we do prophylactic cranial eradication to prevent the brain mets. So another intent of giving is palliative treatment. So in palliative treatment, the aim is to control symptoms and improve the quality of life. So indication for palliative treatment is painful bone mets, presence of brain mets, skin lesion which is eroding this bone, esophageal tumor causing dysphagia, shortness of breath from lung cancer, abdominal distension from liver mets, and hematuria from bladder cancer. So here the aim is to control the symptoms and not to control the disease. Sometimes radiation is delivered as emergency treatment. So here radiation is delivered to reduce pain, bleeding, alleviate obstruction, and reducing complication. So some emergency treatment is moderate to severe cancer pain, spinal cord compression, uncontrolled bleeding due to cancer, and superior vena-cava obstruction. So this is a case of spinal cord compression where we can see there is a compression. So spine mats can compress the spinal cord. Here, swift intervention required. Left untreated can lead to permanent damage. So spinal cord compression and superior vena-cava obstruction are actually two such disease where even we don't have biopsy, we start radiation because waiting for radiation can have very catastrophic effect like paralysis or even paraplegia or asphyxia leading to death. So here if If clinico-radiologically we suspect malignancy and there is spinal cord compression or SBCO, we actually can start treatment without a biopsy. So this is a case of SBCO. Here we can see there's full-blown SBCO effect. So it resulted in breathing compromise, cerebral edema, death. Here also it's an emergency situation. So now coming to some specific site. Now, this is basically the principle of radiation. So now I will discuss about some specific sites. So if you have any questions, you can raise now about the principle of radiation. Okay, I think there's no question, so we'll continue. So we'll take the question at the last. So we'll discuss very few specific sites where the treatment management is rapidly changing. So coming to esophagus, we have to first differentiate is either resectable or unresectable. In resectable esophagus, current standard of treatment is neoadjuvant chemoradiation followed by surgery, and the most common protocol uses cost trial protocol. Here we give radiation 41.4 Gray in 23 fraction with carboplatin and paclitaxel weekly. Actually, there is overall survival advantage of 48.6 months compared to 24 months in surgery. So in today's world, adjuvant radiation is rarely used because of the excellent result of neoadjuvant radiotherapy. So esophagus is one site where actually neoadjuvant has a almost survival advantage of double. That's 100% survival advantage from 28 to 48 months. So here neoadjuvant chemoradiation is preferred. In unresectable esophagus, unresectable may be because of cervical esophagus, medical or contraindications, or esophagus aborting large facial or atria. Here, chemoradiation is preferred treatment with radiotherapy goes to higher dose of 54 Gray, 34 fraction with 3 weekly cisplatin and 5 FU. Now, coming to gastric cancer, primary surgery is treatment in early gastric cancer like T1, T2, N0 clinically or patient with gastric outlet obstruction. However, in T3 or N plus T3, T4 or N plus tumor, now perioperative chemotherapy with float regimen is the preferred method. So if the patient has a performance status of 0 to 1, that's patient general condition is very good, we give float-based chemotherapy. And if the performance status is not good, we give Capeox-based chemotherapy. So in some cases where patient has undergone primary surgery and in T3 or N plus tumor, we actually give adjuvant chemoradiation with intergroup 0116 protocol. That's we give one cycle of chemotherapy followed by radiation followed by 3 cycle of chemotherapy. So in gastric cancer, we actually prefer perioperative chemotherapy than adjuvant chemoradiation. Breast cancer. In breast cancer, neoadjuvant radiotherapy is not established at, so radiotherapy is always adjuvant in breast cancer. So during residency or other time, when you see the in contraindication of BCS, breast conservative surgery, you see the patient should not get previous radiation. So actually, they are not the contraindication of BCS; they are contraindication of radiotherapy. So what you have to understand is in all BCS patients, adjuvant radiotherapy is the must. There is no questions there. So in BCS actually includes surgery followed by radiotherapy. In post-MRM, T3 or T4 or N plus tumor, we have to give adjuvant radiotherapy. It not only improves local control but also overall survival. In rectal cancers, we know surgery alone is not sufficient with 30% of local recurrence rate. So adjuvant treatment with post-op chemoradiation or preoperative chemoradiation followed by surgery were the options. However, if we see all the data, we have neoadjuvant chemoradiation followed by surgery followed by chemotherapy is standard treatment in all rectal cancer except T1, T2, N0, N0. So in rectal cancer, we give neoadjuvant chemoradiation. We wait for 8 to 11 weeks, then we do surgery, then we give adjuvant chemotherapy. That's actually the best available treatment for rectal T3, T4, and plus rectal cancer. So in today's date, only time post-operative chemoradiation is given is when clinically T1, T2, N0 patient is up stage in pathological staging, or T1, T2, N0 with margin positive. So adjuvant radiotherapy is really used in rectal cancer and it's all neoadjuvant chemoradiation. And with this method, we have excellent survival of around 60%. So in pre-op chemoradiation, we have two strategies. We either give neoadjuvant chemoradiation followed by surgery followed by chemotherapy. Here we use 50.4 with 20 fraction with daily capecitabine. It's a 5-fluorouracil based chemotherapy. Surgery is usually done 8 to 12 weeks post neoadjuvant therapy. And adjuvant chemotherapy with Capox for 6 cycles is given. Another upcoming is total neoadjuvant therapy, where we give all of the treatment, that's radiation, chemotherapy, before the surgery. So what we do our center is we use standard long course chemoradiation followed by surgery followed by chemotherapy to most patients. Total neoadjuvant therapy is offered to patients with very good performance status, CRM positive on MRI or lateral lymph node positive, that's obturator or internal iliac or external iliac node positive, or in some cases where patient is candidate for waiting on scholarship, we do total neoadjuvant therapy. Anal canal is one site where definite chemoradiation is the treatment of choice. Here, surgery is only done when there is residual disease post chemoradiation. So 45 to 50.4 grade to pelvic artery plus 5-FU and mitomycin based chemotherapy is given with excellent survival of 80%. Surgery only used as salvage in this patient. Now coming to prostate, radical radiation is given to all. We know prostate is divided into low risk, intermediate risk, and high risk. So radical radiotherapy is given in all risk patients. In low risk, radical radiotherapy is given. In intermediate risk, radical radiation with short course hormone is given. And in high risk, neoadjuvant hormone for 6 months, radical radiotherapy with long-term hormone. That's 2 years of adjuvant hormone is given. So in prostate, IMRT should be minimum for radiation. Thank you.
Any questions? If any questions, this is your opportunity to put questions to Dr. Simit. Dr. Simit, at present, what is the best option for radiotherapy for rectal cancers?
In rectal cancer, we use two strategies. It's a neoadjuvant chemoradiation followed by surgery followed by chemotherapy to most patients. However, if there is CRM positive or lymph node positive, now we started giving total neoadjuvant therapy. That's chemoradiation followed by chemotherapy, and then at the end we do surgery. So it depends upon the patient clinical stage, especially now as the rectal cancer is MRI stage, if CRM is involved or not.
Thank you. We have one question. Why previous radiotherapy is contraindication of BCS or radiotherapy? Dr. Pratima, she wants to ask this question.
No, actually, what I want to highlight is if you see the contraindication of BCS in books, even in Bailey, you see there are the listed are actually not the contraindication of BCS, but they are the contraindication of radiotherapy. So in BCS, radiotherapy is must. That's the thing everybody should learn. So BCS means it's breast conserving surgery followed by radiotherapy. So in all BCS patient, adjuvant radiotherapy is must.
Okay, any more questions? We had extensive discussion on covering most of the general subjects in surgical oncology. I would like to thank Dr. Simit Sapkota for his time and support, and I'd like to thank all the participants for the presence.
Thank you, Dr. Bikal.
Thank you. And next week we are having a discussion on critical care and nutrition. Thank you, everyone.
Okay. Uh, yeah, I think Dr. Sagar has some.
Dr. Shah Gewali has a question. Can the slides be shared among participants? Um, we will prepare a webinar series and post it later on, and it can be accessed for the associate members with the present.
I think I can. I think I can answer Dr. Pratima now nicely as I can see her message. So actually, once a radiotherapy is given, the organoleptics like lungs and heart has certain tolerance. So it cannot be usually radiation cannot be usually repeated, especially within 5 years. So that's why we usually don't repeat radiotherapy because the lungs and heart which comes near the breast has tolerance, certain tolerance, so we don't repeat radiotherapy. Okay, thank you, Dr. Pickle.
Thank you, everyone.